The recording will be posted on the committee's webpage after the meeting. For everyone's reference, today's agenda can be found under the first tab in the meeting materials. As a reminder for everyone, please remember to use the Primary Care Committee email inbox to send updates or questions. And if you are not a member of the committee, please turn your camera off. Now I will turn it over to Chair Dr. Judy Zerzenthal to call the meeting to order.
Great, thank you. Good afternoon, everybody. It is now 2:03 p.m. and I call the June 26th meeting of the Advisory Committee on Primary Care to order. Thank you all for joining us today. I'm going to start with an overview of the agenda. We'll do roll call. After roll call, we'll vote to approve the meeting summary of the May committee meeting. Then we're going to open the floor for public comment. After that, we'll hear from Shane Mofford and Gretchen Morley from the Center for Evidence-Based Policy, who's going to help walk us through our 7 policies and strategies to reach the 12% primary care expenditure target. They're going to help lead us through the original language of the policy recommendations, as well as a summary of folks' feedback. And after reviewing the policy recommendations and the summary of feedback, we'll then discuss and vote on final language for each recommendation. We're then going to review and vote on a recommendation package for submission to the cost board at their July 30th meeting. And after that, I'll give you a brief overview for the next steps for the Primary Care Committee. This is going to be our last meeting for 2024, which is crazy. And then we'll wrap up and adjourn. It has been a great journey, and I think we've made a lot of good progress. So here's to the last meeting. So I'll start roll call, and I'm going to call on members by first name in the order listed on the agenda, which is alphabetical order by last name. When I call on you, please unmute your microphone and let us know that you're here, and then go on mute again. So Crystal?
Here, thanks.
Sharon Brown is not able to make it today. Tony?
Tony is unable to make it today. He did share some feedback with me he would like for me to share as the conversation deems appropriate.
Okay, great. Michelle?
Hi, good afternoon.
Hello. Tracy? David?
Hello, I'm here.
Perfect. DC?
Hi, DC here.
Howdy. Sharon?
Hi, I'm here.
Hello. Chandra?
I'm here.
Hi. Megan? Or Meg, sorry. Greg? Cheryl, I think, is gonna join late. Lon?
Hello, I'm here.
Hi. Katina?
Hi, I'm here.
Excellent. Mandy? Jonathan? We heard you already.
Still present.
Excellent. Sarah? Linda? Sean? Stacy?
Good afternoon, I'm here.
Hi, Stacy. Ginny? And Maddie.
I am here, and once again, Linda Van Hoff is no longer on this committee, and she was replaced by Shannon Fitzgerald, and there is still issues with her getting invites and connections.
Okay, we will make sure that that gets fixed, particularly going forward. Thanks. So please join me in turning to the May meeting summary and the meeting materials. As a reminder, the recording of the last meeting is posted on our webpage. Is there any discussion of the meeting summary or proposed changes to the May meeting summary?
Hey, Judy, this is DC. So I think there's a typo on page 7. It's the paragraph, it's the shortest paragraph on that page where it says The recommendation under consideration is for HCA to increase Medicaid rates, et cetera, to parity with the Medicaid fee schedule. I'm sure that's supposed to be Medicare fee schedule, but
Oh,
Probably-
yes,
probably
that
important
should be
to note that.
Medicare. Let's make that change.
Judy, really quick, it looks like we have a hand raised from someone in the audience, Sean, and I'm not sure if that is Sean West, one of the committee members.
Oh, my guess is probably. Let's,
I turned on
Yeah,
his
can you hear me?
microphone.
yes.
Okay, he's here.
Can you hear me?
Yes, we can hear you, Sean.
Okay, thanks.
Let's also promote him to a panelist.
Here.
Okay, with that change, would someone like to make a motion to accept the summary?
Motion to accept.
A second?
Second.
Perfect. All in favor, say aye.
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 Any opposed? Great. The May meeting summary is approved. Next, I'm going to turn it over to Rochelle for public comment.
Thank you, Judy. If a member of the public wishes to provide public comment, please raise your hand. When you are called upon, please state your name and affiliation, if any, before speaking. Please do not raise your hand more than once. This helps to ensure that everyone has a chance to speak. You are also welcome to provide comments in writing via email at any time. Please remember that this is the time for public comments. Any questions and answer sessions during the meetings are times for the committee members to ask questions only. So let me check to see if we have any public comments at this time. Okay, it looks like we have one. Chris?
Hello.
Hello?
Hello. Sorry. Are you able to hear me now?
Yes, we can hear you now.
Amazing. Thank you. Good afternoon, Dr. Zerzenthal and committee members. My name is Chris Casa. I'm here on behalf of the Washington Association for Community Health. We are the state's membership association of community health centers, 28 of them in this state now, which collectively provide primary medical care, behavioral health, dental, and pharmacy services to 1.2 million Washingtonians, about 55% of whom are Apple Health enrollees. And I'm here today to express Community Health Center's excitement about one of the recommendations that you'll be considering today. And that is recommendation number 6, which endorses the exploration of alternative payment models and suggests setting a minimum percentage of primary care expenditures that should be made through an advanced primary care payment model in order for it to count towards that 12% gold standard. This has the potential to put the state on a path towards truly transforming primary care. Health centers, it must be acknowledged, have a unique Medicaid payment model that helps pay for the team-based care that we know best serves patients. But to borrow a phrase from Dr. Karen Johnson's excellent presentation at the last meeting, it's an encounter-based system that preserves many of the downsides of a classic fee-for-service payment architecture. In previous demonstrations, with value-based capitated payment arrangements in Medicaid, health centers were able to expand their care teams, particularly with community health workers, to conduct affirmative outreach to patients of significant medical complexity and to help address health-related social needs of our disproportionately low-income and underserved patients. In some cases, health centers were actually able to launch whole population health teams to really try to break down those barriers. Just the last point I would add, this is especially timely now that CMS has chosen Washington State to be an incubator of the future of primary care payment through the Making Care Primary demonstration. Health centers believe that more can be done, and we are ready and willing to do it, especially in the Apple Health space, and we commend this recommendation to you to put the state on a path towards the future of primary care payment.
Thank you, Chris, for your public comment. Let me see if there's anybody else that has their hand raised. It doesn't look like it. Judy, I'll turn it back to you.
Okie doke. Thank you for that. And oh, it's in writing too. So next, Shane and Gretchen are going to lead us through a recommendation sort of package. Oh, I have the wrong one. So I'd like to welcome Shane and Gretchen from the Center for Evidence-Based Policy, who's going to lead us through the 7 policies and strategies we've narrowed in on to reach the 12% primary care expenditure target. We're also going to review the summary feedback suggested by the committee members, and then we'll vote on final language for each policy recommendation. So Gretchen and Shane, take it away.
Okay, thanks, Judy. Hi, everyone. So I'm Gretchen Morley with the Center for Evidence-Based Policy, joined by Shane Moford, who also is with the center. I think you know Shane well. We're going to walk you through, as Judy said, a couple of framing slides to start at the beginning before we dive into explanations and voting discussions. We can go ahead and go to slide 2, Shane. Great. So this is what you would have received, I believe, for your homework, just to remind you that there were 7 recommendations for you to be pondering. We're going to be walking through each one of these, so I'm not going to spend a lot of time up front talking about each individually, but hopefully this slide looks familiar to you all and that you had some time to ponder between your last meeting and today. I think we can go ahead and move on to the next. So we've had a lot of conversations since the last meeting, and we have a somewhat new proposal for you from what we hit on in the last meeting, which we talked about prioritizing all 7, knowing that, it could be overwhelming for the cost board to get 7 different recommendations. After we assess the comments we got on them, and we'll walk through this, and then you'll have an opportunity at the end of the discussion to vote on this whole concept. So it can be revisited, but we wanted you to have this in mind as we were going through the recommendations, is that that really the top 2 in top meaning number 1 and number 2, increasing primary care expenditures and increasing Medicaid reimbursement are very specific strategies requiring legislative action coming from this committee. And they had a slightly different feel than the other 5. And we'll explain that a little bit more as we go through, but really the other 5 were ones that were strategies that are already underway, or they can be implemented without legislative action or through some action of some other entity. And so you'll see part of our recommendations is changing some of the language to that this committee endorses the work of, XYZ. So this is sort of a slight shift. And the nice thing about this is it is a package, and then they all, there's no culling that would happen under this scenario in terms of some of them not being in the communication to the cost board. So this is something for you to keep in mind up front. Anything, Shane, you would add to that?
Yeah, just reiterating that this strategy, it does align with the type of feedback we got, a lot of what we heard from action in other areas. But I think the key benefit here too is that it's reiterating that supporting primary care is really a multi-domain activity, and not just the investment in strategy alone isn't going to be enough to get the desired outcome of increased access and improved quality for the population. And we are optimistic that this strategy will resonate with you, particularly as you see the feedback that we received, and then if not, we'll modify it and vote on that. So we'll see how it goes.
Great, thanks, Shane. Let's go ahead and go to the process slide. Okay. So what we'll do is we will put up the original language that you would have seen in previous meetings, review a summary of the feedback from that we received from you all. We did purposely put all the feedback up rather than selecting, some could be summarized together because they were hitting on the same issue. But to someone's question in the last meeting, were were we going to be showing all input received? The answer is yes, and we'll show you how we're doing that. And then you will discuss and vote on discrete policy modifications, and then vote on the final language for each recommendation. And then there'll be that vote at the end on either the package we just talked about there in terms of that sort of 2 and 5 split, or wherever you guys decide to land by the end of this meeting. So that's what we're going to do. And I'll be kicking it over to Judy for those votes that she's well schooled in doing with this group. So let's go ahead and move on then. I think we can dive in. Is there any questions, just even to pause for a second, any questions from anybody on the committee before we get started? Okay, and I can't quite see hands. So if somebody is looking to jump in, if maybe Shane or someone else can flag me, that would be great. Okay, so we'll just dive in then. So recommendation number 1 was increase primary care expenditures. So the original language is what you have here on the slide. Recommend the legislature codify a goal to increase primary care spending by 1 percentage point per year. Recommend the legislature requires agencies to publicly report primary care expenditure ratios of all carriers. And that would be HCA carriers, Health Benefit Exchange, and Office of the Insurance Commissioner. So then we did get some feedback. This was probably one of the meatier ones in terms of feedback, and the most in terms of numbers of folks. So some amendment suggestions were to expand the authority of the insurance commissioner to be able to enforce targets, create a new role, a health insurance commissioner within OIC. We had at least a few folks asking to include some kind of reference to specific consequences for not achieving targets. This was the discussion in the last meeting of sort of adding teeth to the recommendation. And then we had 2 people requesting sort of increase of, or proposing increase from 1% to 2% in terms of those annual targets. So that's the breadth of what we received. And that's consistent with the conversation that you all had in the last meeting. You'll see on each of these slides, we did get some questions for additional information. So the one question we did receive was, how will this policy impact premiums? And so we tried to explain this here. And actually, here, I'll do a first run, and Shane, you fill in if I miss anything here. So each plan could have a different strategy for achieving the 1%, or if you vote 2% goal. And different strategies may have different impacts on the premiums, or no premium impact at all in aggregate. This is really an actuarial sort of exercise. We did hear from Oregon that they did not need to make explicit rating adjustments in Medicaid to support the overall targets. And they saw early success regardless. So there's a lot of different factors going on here, but as we all know, the setting of rates is an actuarial process, and there's really no clear way at this point that it would increase in premiums necessarily. Shane, do you want to add anything to what I just said or amend?
I think that covers it, but for particularly those that ask these types of questions, if you have any additional follow-up questions, feel free to ask them. We'll do our best.
Okay, any questions, any hands up?
I do not see any.
We have one
I
hand up.
apologize, DC. Yep.
Yeah, hi. So I'm sorry if this is a question that's been somehow answered already, but I thought there was discussion around the 12% target and how that is kind of interdependent, or might be in some way, I'll just say, not carried out in the way we're thinking in a mixed funding model where there are both prepaid services and fee-for-service services. Is the intent here to include all primary care type services, like prepaid, capitated, so to speak, plus fee-for-service, or is this looking at the fee-for-service side only? And should that be more explicit in terms of the wording of the recommendation? I know there's I think recommendation 7 or something gets into some aspects of that, but I wasn't sure if these can be considered separately or if they need to be considered together for that reason.
So just to make sure I'm understanding the question correctly, are you asking if in this recommendation, we need to specify the portion that's applied to prepayment.
I guess my
Versus
question is,
targets for
do
fee for
primary
service.
care expenditures include those of all natures, meaning
Yes.
fee for service, non-fee for service, prepaid, whatever it is, or is it aiming specifically at the fee for service side of the business?
This is a global policy, really. So this is your statewide expenditures inclusive of any methodology by which they're paid. But you are absolutely correct that we do have additional considerations and some of the other recommendations that get at the methodology for payment. And I think that's a great call out because as you've heard in prior presentations, it's not just how much you pay, but how you pay that can impact sustainability of primary care and whatnot. So we'll be talking about that. And I think you actually got the correct recommendation too, but as part of 7. So this target here, all forms of payment.
Thank you.
Yeah, thank you for the question.
Any other questions? Okay, well, why don't we go to the next slide? And so this is, this is how we'll roll through this meeting in terms of trying to sort of integrate the discussion as we go. So this is sort of working into the previous language, the input that we received in our proposed way of addressing that recommendation. So the first one is sort of a straightforward one, and you'll be doing a vote in just a second on maintaining it as 1 or increasing it to 2. So that's sort of, it's at least straightforward in terms of how to describe it. The third one is, and you'll see this a lot in our recommendations, is that, this group's been doing a lot of good work and understanding all these recommendations. There's not time for actually defining, say, what are those teeth, and so you'll see some language that explicitly is recommending, the board or the insurance commissioner or someone to do something specific to make sure that your concern is followed up on. And so you can see here that the recommendation we propose is recommend that the Office of the Insurance Commissioner submit a report to the legislature by 2026 describing how payers will be held accountable for achieving primary care expenditure targets. This report should include making recommendations for changes to the OIC's regulatory oversight authority if necessary. And so that last clause really gets at the technical and statutory processes and discussions that would need to happen to determine, how to change the actual authority that the OIC has. And that's not something that we as a committee either have the time or the ability to kind of delve into all the pros, cons of all the options. So let me pause for a second. I'm gonna keep hitting you up, Shane, after each one, just to make sure that I'm giving a complete explanation, and then we can open it up to questions to the group.
Yeah, I think that was great. Modifying a state agency's authority over how they operate is a pretty big deal. And we are thinking that this is a good compromise solution where it's setting a path for getting teeth around this policy, but it's allowing for the time and the experts in that area to explore, vet, and produce the right set of options to accomplish that.
Great, thanks, Shane. Okay, open to questions or comments.
Dr. Morelli?
Yeah, thanks for including the second part, Gretchen. At least we're heading in I feel like that's heading in the right direction. I would say one thing, just because words really matter, I would recommend removing the should and just say submit. That's our recommendation. Not that they should do it, but that we really want them to do it, just to be so, because that can be should can be interpreted in many ways. So I would remove the should. And then just as a comment, I was one, I have no problem telling everybody, I was one who recommended that this should be 2%, not 1%. And just so everybody knows that it was me, at least as one of the people who recommended that. And I think you won't be surprised based on my comments from before. I just think it's been a long time coming already. And I just feel like we need to get moving, and we cannot delay any longer. So I just think we need to get there faster. Thank you.
It looks like Jonathan has his hand up.
Okay, go for it, Jonathan.
Hi, so is this a forum also to suggest language amendments to what's written in orange?
Yes, and that's essentially what Cheryl was just doing as well with her request to remove should. So
Great.
yes, please do.
So I was hoping, so it says describing how payers will be held accountable for achieving primary care expenditure targets. I would like to put a comma after that, and basically say like beyond publicly reporting primary care expenditure ratios, because I feel like the way it's currently written leaves room for just transparency being the sole accountability mechanism.
Okay. Okay. Additional thoughts, responses, reactions?
Looks like Mandy had a question.
No, I did not. I'm sorry. I was trying to check the members for any questions and I accidentally hit the hand raise myself. Sorry about that.
All good. We all want to get into the conversation.
Although I do see another hand raised. Oh, it's Jonathan again.
Hi, yes, just in the spirit of passing along Tony Butrell's comments, what he had written to me. So this is me using his voice, not my own. He said, I think this is the clear #1 priority.
Okay.
Yes, he doesn't have the ability to know that we've magically made it one thing, so we don't have to kick anybody off the island.
David, you have your hand up?
Yeah, Gretchen and Shane, I think you've done a nice job of taking the feedback and editing the strategies. So nice job on that. This is where the premium question, I think, comes in. And I'm just saying this as a comment. I don't think we need to do anything about it because I think the language allows for it. But I'll say it in case anybody has any reaction, which is if we're at 6% of total expenditures in primary care today, and we increase 2 percentage points a year, that's a 30% increase in payments to primary care. So a lot of extra money going into primary care. If there isn't commensurate savings outside of primary care, then from a carrier standpoint, those premiums will go up. And that's something that would be visible to the OIC. And presumably the OIC would articulate how they would address that. But I thought it might be helpful for folks to see those dynamics.
Thank you, David. And you don't propose right now a shift. It's just that's sort of the, I mean, really your comments kind of hitting on the 1 versus 2 percentage point as well. And it really is how everything shakes out.
Yeah, and I agree with Cheryl. It's important to get as much money into primary care as possible. I think folks just need to be, because as we make these recommendations, I think each of us will have expectations of how things play out after this and what the OIC does with this. And there will be some constraints because in order for a payer to do something and be held accountable, the payer is contracting with providers and there's a fixed pot of money to be spread across all providers, not just primary care, but hospitals and specialists and so forth, unless the premium increases.
Okay. Thank you, David. Any other Chandra?
Yeah, I think that was kind of my question too, is that, I think having an accountability mechanism makes sense, but there's a way that you can do it that maybe keeps people from operating in bad faith. And then there's a way that you can do it where it kind of forces the system to have more money in it, increases premiums, and then also potentially has, I'm thinking of things like financial penalties that can also add even more costs into the system. So I think there's maybe an element of, you know, in this report, would sustainability of total cost be a piece of it? And I guess how much thought would be going into some of these recommendations around accountability mechanisms?
I'll just remind folks that it's a percent of spend. And so if you add money in, like part of the percent idea implies that there's redistribution or change in how things are reimbursed. So just adding new money or changing things by premiums will not change the primary care percent spend.
I think that I would still have the maybe thought that this could be something that could be structured well, that looks at the total system and encourages dollars moving around, or it could become punitive and add cost to the system. It just depends on how it's structured.
Do you have a recommendation for language modification? So presumably we had add, let's see here, primary care expenditure targets, comma, beyond publicly reported transparency measures. Maybe we throw in another comma or a new sentence that says including consideration and should include consideration of the impact on healthcare affordability in general, or something to that effect.
I'm thinking more of, is this OIC report going to partner with some other areas like the Health Cost Board or this group on how that would be structured to still achieve the goals and also look at the system impact? I can't tell if this is saying that the OIC just writes their own report without input.
This doesn't currently prescribe a process for vetting the recommendations as written, but if that's something that the committee would like to add, we can certainly add that language.
Any specific language suggestions there? Okay, how do you want to handle this, Shane? Do you want to wait till we get there? Do you have a revised paragraph that you're working on, right?
I will.
We'll have that. Yes. Yeah. Was held accountable for achieving primary care.
All right. Well, so essentially how the process will work is we're biting off each of the discrete policies to vote on one at a time. So we'll vote first on the 1 or 2 percentage points, and then after that we'll vote on the addition of this block of orange language about the OIC. Before we vote on that, we can wordsmith it a little bit more. And actually, when we get to that screen, I'll be able to edit it a little more real time, and it'll be a little bit easier to incorporate some of your feedback. So maybe what I'd recommend is think about specific changes to the language that you'd like to see. I know that's actually a pretty big block of substantive policies. So take some of this time before we get there to think about that. And then unless there are other questions or comments on this slide, we could probably go ahead and transition to voting on the 1 or 2%, and then get back into the weeds of that paragraph. If that seems like a good process for everyone.
And one note I would just ask, just so I'm not putting the HCA staff on spot either, is I'm just curious if something about the language, is there language that would be typical sort of language that you would see for anyone in, that's being asked to either, like work with the cost board or engage with the cost board, or sort of, is there some kind of language that feels right from how the cost board operates? And figured the state folks might have a gut reaction on that too, that might make that connection then that might encompass a number of these comments. So think about that. Okay, why don't we go ahead and move to the 1 or 2% vote? That's slide 9. Are you able to go there, Shane?
I did. Can you see it?
Are
Yeah,
you frozen?
I can see it.
Oh, it's funny. It's not coming up on mine. Oh, huh. Okay. You, I think I kicked this over to Judy while I'm figuring out what's going on with my screens.
Okay, that sounds good. Would someone like to make a motion to pick one of these percentage points for us to vote on?
This is Katina. I move that we increase to 2% annually.
Is there a second?
It's Sean West, second.
Okay, any discussion? Okay, all in favor of the percentage target should increase 2% annually, please raise your hand. And I'm assuming the folks in the room are getting the count of this.
Yes, we have 10 hands raised so far.
Okay. All those opposed?
It looks like we have a few hands raised for opposed. 3.
Okay. Or two or three. It's changing a little. Okay, well, I think that the recommendation passes to increase 2% annually.
All right. So next we'll be voting on the recommendation related to the Office of the Insurance Commissioner for the discussion we just had. I am going to pop out of this presentation mode so I can make some live edits, but I'll continue to share. Okay, so the first request was after expenditure targets would be reported trends measures. Remove the word should. I do want to resurface the conversation about the interaction with the cost board. Does anyone have any recommendations, or did HCA staff want to share any context on typical language that might be included for those that interact, or ideas on how you think that should be structured based on how that operates?
I'm also wondering if just changing the word describing to proposing leaves room for, this is a proposal that then would move for some sort of discussion rather than a prescriptive report.
Any other discussion or recommendations on the language? And then after that, we'll ask someone to move it. David?
Yeah, I think it was maybe Jonathan who recommended that first edit, the beyond edit. I don't know exactly what that means. I wonder if you come back on and say what you mean by that.
Yeah, happy to. So my thought process here is that in the original draft of the recommendation, the only sort of enforcement mechanism that we have in place is that insurance companies would publicly report the percent of total expenditures that is on primary care. And sort of our discussion has been largely surrounded, at least in my estimation, about adding more teeth to the recommendation of 1% per year. And the way it was currently written, I could envision some version of a report saying, hey, transparency and transparency alone is sufficient. And so if the spirit is to add additional enforcement mechanisms, I was proposing this language so that would be prescriptive to propose additional enforcement mechanisms beyond just requiring public reporting of what's spent on primary care. Does that make sense?
I think so. I think what you're saying is if a carrier reports a number that's below the target, we don't want any ambiguity that reporting itself satisfies the expectation.
Correct.
Right?
I would say one could argue that public reporting is an enforcement mechanism. And I thought the spirit of this proposal was for the OIC to propose additional enforcement mechanisms beyond just public reporting. But since public reporting is an enforcement mechanism, I thought this language could be more prescriptive that we would be interested in additional enforcement mechanisms beyond transparency.
Okay. I don't totally get it. I think the fact that it says achieving primary care targets makes sense, but I don't think I need to belabor the point. You know, if the OIC has the ability to prescribe that a carrier do certain things to achieve the target, is that what you're getting at, or you're just saying that you don't want a carrier to get a pass if they don't meet the target?
Good question. I'll try to rephrase. So, for example, the Rhode Island Office of the Health Insurance Commissioner has a regulatory power of rate review, right? And so, if an insurance company proposes an increase in rates but did not spend a certain amount on primary care, the Rhode Island Health Insurance Commissioner, in my understanding, has the ability to reject that insurance company's premiums. That would be a regulatory power beyond transparency of just reporting how much someone spends on primary care. We had talked about giving the Washington Office of the Insurance Commissioner maybe more powers than it currently has. It currently does not have a power like that rate review process that Rhode Island has. But perhaps it would be much for this committee to just suggest that the OIC has that power. So what we're asking is that the OIC think about what powers might make sense for them to have additional requirements of payers and then propose that to the legislature. But at baseline, I think our discussions have been, let's require that health insurance companies publicly report how much they spend on primary care, but we haven't had anything beyond that. To actually require that they increase. We only require that they report. And so if a health insurance company did not increase anything on primary care, there's no enforcement mechanism beyond just daylight. And so this was a proposal for the OIC to come up with additional mechanisms to propose to the legislature beyond the transparency.
Okay, that's helpful. Thank you. I think I get what you're saying, and I'm having a subject-verb matchup problem when I read the language.
Well,
but I don't have an easy solution of how to modify it, so I'm not going to get hung up on it.
I'm going to just share that in Oregon, they had a similar target and their enforcement mechanism was performance improvement plans. So they just asked carriers to submit some information on how they would meet the target.
Got it.
Okay. Are we ready for someone to make a motion?
Why don't we go ahead and get the full slide up first so people are seeing the.
We have the language for the vote up.
It's up, yeah.
Okay, go for it.
Does someone want to make a motion to approve this?
Move
This
to
is
approve.
second.
Great. All in favor, please raise your hand.
We have 14 hands raised. Judy.
Great. All opposed, raise your hand.
Just wait 1 second. Sharing
It looks like just 2 people have their hands raised.
Okay, so the motion passes. And so this slide is putting it all together. So the 2 percentage points per year and the changed language below. So does anyone want to make a motion about this first recommendation?
Yeah, Chair, I'll move to approve recommendation number 1 as written on the screen.
Perfect.
Second.
Thank you. Any discussion? Okay, all in favor, raise your hand.
You have 12 hands up.
Okay, and all opposed, please raise your hand.
Just 1 second, Judy, just to allow everybody to lower their hands before. Thank you. Everyone's lowered their hands. Go ahead.
Okay, it looks like no one is opposed, so the motion passes.
I have 1 person.
Oh, do you have one person? I don't have that person.
Yeah, it
Okay.
looked like there was 1.
Oh, yes, Michelle. Great. Okay, number 2.
Okay, moving on. So now that we know how this is going to work, the rest are going to be smooth as glass. Okay, so the second one was around increasing Medicaid reimbursement. And so we had the original language, which is HCA should increase Medicaid reimbursement for primary care services to no less than Medicare rates by 2028. And then HCA should implement the increase using existing enhanced fee schedules to minimize confusion. Let's go to the next slide. Okay, we got quite a bit of feedback on this. We had someone advocating for increases in Medicaid reimbursement across the board and not just primary care. We had 2 on Medicaid reimbursement for primary care should target 100% of Medicare by 2026. So essentially it's moving up the date, I believe that is what that means. And then add greater specificity to reflect how the policy would be implemented and reference legislative appropriations. And if we did not put a number in front of it, this is right, Shane. If we did not put a number in front of it, this is one person's input, right? Okay. And we wanted to do that for complete transparency in terms of the input that we received. Okay, so then requests for additional information. One question was verifying that mandated increases in primary care reimbursement can be reflected in managed care capitation rates. And so this is a similar response, at least in part, to one that we had in the first, for the first policy. The managed care capitation rates would be adjusted to reflect policy changes based on the requirement of actuarial soundness. And in that process, that rate adjustment might not be dollar for dollar, depending on estimated impact of the change on other services. So in terms of offsets or increases in other areas, and that's part of that actuarial process. And then the other question, we request to know how this policy would advance the state towards 12% goal. That is not something that is available at this time. Is that the right way to explain that?
Yeah,
Yes.
that's correct. We do not have that number yet.
Okay, so let's open up. And then this is a proposed enhancement or change before we open up for questions. We have they were kind of piecing together different input we've received, and help me explain this, Shane, in terms of so there's a question of whether it's 2028 or 2026. There's some additional language here in speaking with HCA in terms of direct HCA to implement the legislative increase by using, and this makes it more specific to the fee schedules that are available, enhanced primary care, enhanced pediatric fee schedules, and revising those fees to closely align with service codes and the cost board's adopted definition of primary care services where there is any discrepancies. And then the payment rate for any services on enhanced fee schedules already reimbursed at or above Medicare equivalent rates should not be changed. And then it should be implemented no later than 2028 or 2026. So those are input received from HCA as well as the comments we received to try to make it a very specific and clear proposal. Anything else you would add, Shane, from?
Just to connect the dots to the conversation we had in the prior meeting, there was, for example, a question about what I believe it was nurse practitioners that are providing primary care be able to get the same rates, or would it be different? And it doesn't address that explicitly here, other than to say that these fee schedules actually do apply more broadly than just primary care. And so what I'm trying to say is that some of the conversation and some of the concerns raised about how this would apply, these policies generally do address those concerns, even though it doesn't state the rationale why. And then I don't know if anyone at HCA wanted to provide any additional context around the fee schedule or not, or if that was actually just kind of the main point there.
Sure, I could talk a little bit about the fee schedules. So we already have some enhanced fee schedules that involve certain codes for adults and pediatrics in primary care. And this would be far, far easier of an implementation if we just used the fee schedule sets. It would be much harder and longer to do in other ways. And so that's why we're recommending that, because it's an easy way to do. And then revise those fee schedules. Those fee schedules were set in 2014. I think the pediatric ones have been set a little bit after that, but they basically haven't changed since we've started them. I think pediatrics has added some codes, but the adult one hasn't. And so we've compared the two, and there are some small differences between our primary care spend codes and these fee schedule codes. And so we added this recommendation to just line up those fee schedules with what our primary care spend definition is. Cheryl?
Yeah, just a clarifying question around that. When fee schedules means you mean the CPT codes that are included, not right, not the amount, and that's the generally accept, like there's a general definition of that. I just want to make sure, because when you first read it, I was like, do you mean the actual amounts or do you mean the codes? But if that's the general, if everybody understands that who would be reading it, that's fine. I just had a question.
Okay. Chandra?
Oh, yeah, I had a question about how much Medicaid pays today compared to Medicare. Like, are we talking about, a 10% increase? Are we paying 90% of Medicare on Medicaid, or is it 50%? That might impact if you would want to increase those rates a little slower, or if it's something that could just be done in a year or two.
That is a great question that I don't think I know the answer to, because it varies by codes. And so the answer is it depends. We are working on that analysis now, but I think in general, we're somewhere around 60% of Medicare. So it's a larger gap than a smaller gap. That being said, in a few days, July 1st, there is a rate increase on these two fee schedules that's going into effect because part of our 1115 waiver requires that we get up to 80% of Medicare for primary care, behavioral health, and obstetrics. And so the legislature voted to take the first step in that. And I can't remember how much it's being increased, so I shouldn't say. But I know there is a rate increase that is happening July 1st.
So Medicaid will be at 80% for primary care?
No, not that far. It's just a step. I think we have, and again, I don't know that I'm exactly remembering, but we have some time. I think we have like 4 years to get there. So we aren't going all the way to 80% in this first go round, I think. We're just taking a step, but I can't give you more information than that right now.
Okay.
Sean?
Unless there's more questions, I wanted to make a motion to approve recommendation 2 as with the friendly amendments proposed by the Healthcare Authority and implementation of 2026.
Okay, is there a second?
I will second that.
Any discussion? Jonathan, it looks like your hand's raised.
Yes, one point of discussion that I want to read on behalf of Tony Butrill. This was something he had some comments on, so would I be able to read in his voice for this?
Sure.
Just going to read verbatim. He says, this one is tricky. There's no doubt that Medicaid reimbursement should be increased, but I don't think that increased Medicaid reimbursement should be tied directly to increased primary care expenditure. Medicaid increase should ideally occur across the board, not just in primary care. If we lobby for a Medicaid increase exclusive to primary care, we risk losing the support we currently enjoy from specialists to increase primary care investment. Increasing Medicaid rates will be expensive. If the legislature funds increased Medicaid reimbursement and sees it as tied to primary care increase, it is unlikely that they will do anything else to support primary care investment. Increased Medicaid reimbursement does not support an all-payer policy, nor does it support alternative payment methodologies, both of which are essential elements of effective primary care investment. So it would be a poor substitute for an across-the-board increase in primary care expenditure. So I'd, Tony, support increased Medicaid reimbursement across the board, not linked to primary care investment. That was his total feedback. So it's my interpretation is that his proposal is changing it to parity for all services rather than only primary care services.
Great. David?
Judy, a few minutes ago, you talked about where the legislature is today with the 80% and the timeline that they're on. Just to clarify, would this, if we were to recommend this and the board passed it on, would it be accelerating what the legislature has already agreed to?
I believe it would be accelerating and it would be going higher than what we're required to do by CMS in the 1115 waiver.
Got it. Okay, thanks.
And I will say the legislature gets to decide whether they want to follow these recommendations or not. So yes. Any other discussion? Okay, so all in favor, please raise your hand.
You have 11 hands up, Judy. 12.
Okay, great. Please lower your hands. Maddie, can you please take your hand down? Perfect. Okay, then if you are opposed, please raise your hand.
One hand.
In this instance, I don't know. So a procedural question here. I, as me, voted in favor. I don't know, being absent if he has a vote. My hand up in this instance is, if he does have a vote being absent, is Tony's vote to be opposed.
No, if he's not here, Jonathan, he wouldn't have a vote, but thank you.
Great.
Yes. Okay, great. The motion passes. Number 2, we were much faster than number 1. Let's go on to number 3.
Excellent. Okay, good job, guys. Okay, so number 3 is multi-payer alignment. So if we can go ahead and go to the descriptive slide. Okay, so the original proposal was committee support for the multi-payer collaborative's work in aligning standards, quality metrics, practice supports, and payment models. The collaborative's efforts to align the primary care transformation model with the federal Making Care Primary program. And the legislature advanced multi-payer primary care alignment efforts, particularly for state-funded plans to participate in Making Care Primary, in a Making Care Primary aligned transformation model. So then we got a little bit of input. Endorse the state's multi-payer adopted policy design. I think it's funny. It's interesting, Shane. I read that originally as there's an upcoming maintenance of understanding that the plans are working on, but that's not public. But this actually reads more support for the actual PCTI, PCTM design. So did we end up modifying this one? Let's see, 21.
Yeah, I think we summarized it generally and just changed the word to endorses, right. Mainly because that information isn't public yet, so it'd be very difficult to approve something that hasn't been seen.
Right. And this is what as we were saying in the beginning, so the concept of endorsing what other groups are doing that are all going in what you think are the right direction, kind of allows you to support that work, say you support that work, but not having to delineate sort of specific areas of support or detailed areas. So with very minimal changes to this one. So questions, discussion?
I think particularly for the person that submitted the feedback about endorsing the more specific policies, if you have any recommendations on if these need to be tweaked at all, we can certainly do that. Like I said, we are trying to thread the needle, given that we know that a lot of the committee members haven't seen any of those policies, so it would be hard to endorse them. Jonathan?
This is a question for Judy and HCA staff. Question if the second bullet should be transformation initiative rather than transformation model.
There you go.
Yes, it should. Nice job.
Good flag, Jonathan. We've been doing editing of an amazing amount of documents to catch that. So big gold star.
David?
Yeah, Shane, I submitted a comment about alignment, and this looks fine to me.
Yes,
Great.
And you have several members of the multi-payer collaborative on this call, so. Okay, shall we go to you, Judy?
Yes, would someone like to make a motion?
Oh, this is
Move to
David.
accept the recommendation number 3 on the screen.
Thanks. In a second. Perfect. Any further discussion? Okay, all in favor, raise your hand.
The 14 hands.
Great. Please lower them. And all opposed, please raise your hand. There's no one opposed, so the motion passes. Next.
Okay. Recommendation 4, patient engagement. So the prior draft language, payer and purchasers provide education and incentives to promote utilization of primary care and preventive services, support HCA's effort to participate in making care primary and the primary care transformation initiative, including support for pursuing resources for eligible primary care practices to grow capacity to provide comprehensive whole person primary care. Legislature should fund a study to conduct an opportunity analysis of patient incentive programs that could be implemented to increase engagement with primary care providers while improving patients' health. Promising feasible options should be pursued through the appropriate authority and operational processes. Okay, so then we had one suggestion in terms of sort of appropriate agencies should allow for incentives to promote utilization of primary care services. And then we propose a somewhat simplified version of what was in that original recommendation. And some of this goes along with, like we were saying, the whole sort of endorse language, knowing that there are other things going on, or there are other entities that could be working on this. And so what we have here is that, what did we originally have, Shane? We had for endorse, it was just 3 bullets, I'm sorry. So the committee endorses, and then HCA's efforts to participate in making care primary and the primary care transformation initiative, including support for pursuing resources for eligible primary care practices to grow capacity, to provide comprehensive whole person care. So really sort of tying that into the primary care transformation initiative that is underway, and that is a clear area within that initiative. And then adding sort of to that comment we received, any state agency efforts to support availability of employee or member incentives to access primary care services as a place where, the state has some level of direct oversight in their contracts to encourage that. So let me pause for a second. Shane, anything you would add about the shifts we propose?
No, just happy to take questions and discussion.
Okay, open for discussion. Oh wait, there's a hand up. Lon?
Yeah, on the first point, I see primary used 4 times. So my suggestion is to remove the last primary, which is we already specified that primary care practices to provide comprehensive whole person care. And the second point, any state agency efforts to support availability of employee, can someone specify what availability of employee means?
What's availability of employee incentives or member incentives?
Oh, gotcha. Okay, so the member being the employee, and that's the incentive. Okay, thank you.
Yes, there we go.
Thank you.
Yes, sometimes it's the order that makes it change what it feels like the meeting is.
It looks like David has his hand raised.
Great, David.
Yeah, Gretchen, just wanted to comment. I like how you modified or stated that second bullet, because there are some regulatory limitations to how carriers can structure incentives and how much money can be allocated toward those incentives.
Mm-hmm.
Candidly, we were curious if we were going to thread the needle on that comment, right? So thank you for endorsing.
Yeah. We're trying to spare you all the, sausage making of that threading the needle. So, okay. Any other comments? I'm not seeing any hands up. Okay, I think it's to you, Judy.
Excellent. Would someone like to make a motion to adopt this recommendation?
I'll motion to adopt number 4.
Second?
Second.
Any discussion? All those in favor of adoption, please raise your hand.
We have 13 hands, Judy.
Great. Give people a chance to lower their hand. All opposed, please raise your hand. Looks like no one is opposed. The motion passes.
Okay, workforce development. So the original language was the legislature should prioritize funding for state primary care workforce initiatives as collaboratively identified through the Health Workforce Council, which you heard from. And then we can go to the next slide. So one of the suggestions was, support the recommendations of the council. And that was actually very much in the direction of some of these other changes that we've made in terms of endorsing that work of another entity. No reason to reinvent the wheel, right? We did get a question about, what recommendations the Health Workforce Council has that support primary care. And we put some in the slides. I'm not going to read each one of these word for word. These are from the Health Workforce Council's annual report from 2023. And while they don't specifically target only primary care, they affect multiple lines of practice, but they would, lift that primary care boat as well if they were put into effect. So let me pause. Shane, anything you would add on that?
I think I did we actually received multiple comments about supporting the workforce recommendations, and I didn't actually indicate the count on this slide as we did in others, but this one had more than one person supporting. I think 3 people actually mentioned it. Just to note that.
Good flag. Yeah, no, that's a good flag. And then if we move to the recommended change, and we can go back if I'm going too fast or any of these, make it very simple. The committee endorses the Health Workforce Council recommendations that would increase access to primary care services. Okay, so open it up to questions, comments. I am not seeing any hands. Okay, well, I think I'm going to kick it over to you, Judy.
Excellent. Would someone like to make a motion to adopt recommendation number 5?
Move to adopt.
And second?
Second.
Any further discussion? Okay, all in favor, please raise your hand.
We have 13 hands raised.
Perfect. Please lower them. And all opposed, please raise your hand. Okay, no one opposed. The motion passes. Number 6.
Okay, only 2 more to go. So use of alternative payment models. So originally the language was following the 2024 reporting of primary care expenditures by the Healthcare Payment Learning and Action Network category. The committee may make recommendations to the cost board for the portion of primary care expenditure that should be tied to alternative payment methodologies for expenditures to count towards the expenditure growth target. So that was a very sort of forward-thinking wording. So we felt like that had to be changed from just a, kind of a timing or a, perspective. Why don't we go to the next? Yeah. So in terms of, we had one suggestion around going to 50% of payments should be through 4B by 2030. And so we provided the information there of category 4B specifically involves integrated payment and delivery systems where payments are designed to support comprehensive coordinated care across multiple settings, which may include shared risk, financial risk, and population-based payments. So that is, I think that was from one person, Shane. That was, yeah, one. Okay. And then we have a revised proposal that makes it a little more specific to the work going on. Let's just walk through that. It's endorse HCA efforts to track primary care expenditures using the HCP-LAN APM framework categories and to make future recommendations on modifications to the expenditure targets based on related findings. This could include setting a minimum percentage of primary care expenditures that must be paid through more advanced payment models for the primary care expenditures to count toward the annual expenditure target. So the idea there is that that second clause is saying, that you support that consideration of a minimal percentage rather than designating that percentage now. Shane, what else would you say about our proposed modifications?
I think what we were trying to capture in part is that we don't know where we're at yet. So part of the next data collection will show us where we're at. And part of that will afford HTA, they're actually collecting and calculating and reporting the actual expenditure amounts for this. So just to connect that dot if that wasn't obvious. But they could theoretically better inform a strategy of what that target could be. There are considerations like capitation can be really difficult for very small practices, for example, or risk sharing can be difficult just due to small numbers or the infrastructure investment required. So by supporting the work of HCA, kind of charging them with actually measuring and then making recommendations in the future, I think it just allows for a little bit more of a glide path that's data informed. And so that's what we're pushing for there. Sharon, you had a comment?
Yeah, I do have a comment because when I'm looking at the original language, it sounded a little bit more active on the part of the committee, where the committee may make recommendations. We're here in the final language, we are just saying we endorse the efforts on the part of other people. So kind of, throwing away or advocating our agency with this, was that the intention? Or are we saying like, we believe that the healthcare authority's efforts using the HCP land model basically takes care of the previous language?
So I think there's a couple of points on this. One is that, we tried to, I'm going to skip ahead just a little bit. We tried to bucket the recommendations into things that would explicitly require legislative action versus things that could, that are either already underway or that could be implemented without legislative action. This one is actually an interesting one. We put it in the category of this is something that the committee could support because it's the right direction and it doesn't require legislative action. But we tried to incorporate this concept that, based off of what HCA finds, they could make a recommendation that would impact how the measurement of the 12% is calculated. So this one is, I think, a little bit unique in concept because it's kind of riding the middle road a little bit, because there could be potential future legislative action, but until it's measured and studied a little bit, knowing precisely what that amount is, it might be difficult to defend it. So like I said, this is just really falling into that category of it can't, like, action can start now on it and it doesn't require legislative action. And we really put it into that group instead of putting it into the legislative action bucket.
Okay.
It's a little, it is a little bit subjective. So this is, provide that feedback.
Right. That makes sense.
And Michelle Cosley has her hand up.
Yeah, hi. So just a little clarification. So on the last sentence there regarding the minimum amount going through an APM. So are we saying, for example, if the target was 50% and somebody comes in at 45%, then all of those expenditures would not count towards the primary care target? Is that kind of what we're, yeah. Okay.
Yeah, and this is actually based off of a conversation we had with Corey King, or that the committee and the is he deputy insurance commissioner in Rhode Island, but he had talked about this is a strategy that they were exploring there to advocate for use of alternative payment methodologies. And we've had numerous speakers say that it really is about how you pay, not just how much you pay. So we are trying to thread the needle between keeping some action, indicating a policy that could potentially be taken based off of what other states are looking at, but not forcing that to be an action in the short term, because we don't really know where we're at yet.
I mean, I'm all for APMs. I'm a huge supporter. I'm just wondering if that should be a separate target and not to just, because I mean, if you just say you're going to throw out those expenditures, I mean, that's really not a true picture.
Yeah, that makes sense.
That's related to my question. That second sentence, because it's not a recommendation and just a possibility that's being considered, would it be better to take out that last sentence, but include in the first sentence, endorse HCA efforts to track and set targets for primary care expenditures? So then you're covering that you do want to have some targets and you want to make future recommendations, but that last sentence is just kind of a what if type sentence. So like in the first sentence, I just say to track and set targets for primary care expenditures. And then that way you're covering both the monitoring and setting some guardrails or targets around it.
Maybe like for primary care expenditures tied to an
Pretty basic, but that might get over the finish line.
I could support this one. I probably wouldn't support it in its original form.
Okay, other input, questions?
Crystal? Oh.
Yeah, my concerns or kind of comments were very similar. The actual action we've taken so far, and the first recommendations could really occur just through more of a pay for quantity, right? This is our one opportunity to really talk about how we're going to move the needle around paying for quality and population health. So I appreciate the efforts to change the wording so far. I wonder if there's an opportunity to make it, maybe give it a little bit more teeth, like we said before, and say something to the effect of endorse the efforts to track. And in my mind, it would be setting like an increasing allotment of the 12%, right? We've talked about the 12% before. Now it's how do we show that we're setting like targets that increase over time, the percentage of that goes into more it's away from fee for service.
Is there an add at the end of this sentence that does what you're saying in terms of track and set targets using the land categories? I'm not sure how we would say, like, because I'm just thinking of your point there of like to increase kind of however you refer to those higher end categories as a percentage of the, meeting the 12%.
Mm-hmm.
Something like that. Shane, do you have a brainstorm at all?
I mean, it's softer, but we could start there and then make it harder. So with the goal of increasing 8% of primary care expenditures paid through
advanced payment models or advanced.
Should we specify? The 4B was in the original recommendation. I wonder if we should through population-based payments or gonna go ahead. It's cleaner to read. Dr. Morelli?
Yeah, thanks. I mean, I think, there's been I appreciate adding this. There's been, new information that we really haven't made much progress in really moving towards population payments, right? Like we're stalled. Even in Medicare, we really haven't gotten where we want to. And I think without being explicit about where it is we want to go, especially with commercial payers, like we're never going to get there. But I don't know. I think it might have been me who submitted the 4B. So, which you guys probably aren't surprised to hear because of my comments at the last meeting. But I do feel like it's important. And yeah, that's why, I didn't say 100%, like 50%, because there's small practices and there's this and there's that. But I want to be able to support this. And I feel like it's going far enough. And I think I'll just say by adding that, I feel better about it.
Okay, thank you for that. Yeah, it really is hard to set that concrete target as a policy statement without knowing where we're at. And I think truly what the opportunity is, because as I mentioned before, 4B isn't going to be the destination for every practice, particularly the small ones. And I don't know if the 50%'s right. And so this was really just trying to create like some momentum without committing to the policy action that at this point is a little bit ambiguous. But thank you for chiming in that. Crystal?
I wonder, we put some dates around some of the other work. Maybe what might make us feel a little bit better is we know we want to quantify these other elements, and that's fair, and we take some time to do that. But maybe putting some timelines around this as well, like once that evaluation is done, maybe by 2026, that there's been some movement. You know what I mean?
Yeah. And then for those of you at HCA, so just thinking about when you would even get the data, it would be the next reporting cycle that has the APM data. So that would be, is that this year or is that next year? 2025?
That's the end of this year that we ask for that. So yeah.
So would a strategy
release it sort of beginning-ish of next year. Spring.
So if we are to get more concrete and include a date, would 2026 be appropriate for like an HCA recommendation on APM targets based off of where the state's at?
Yeah, I think so.
Okay. Okay, let's see here. All right, so the APM target, we need to be more specific here. So recommendation for 8% of primary care expenditures paid through category, well, paid through, I'll use the same language as above.
Actually, I'd say even potentially that we'll have this data next year at this time to present to the committee, to have people sort of think about what they want to do next. It's a little bit foreshadowing of the end, but when we come back next year, we'll have some of this primary care spend data, and we'll just have more information. And so then there will be the opportunity to either keep these recommendations or tweak them somewhat, or, sort of, this is working, this isn't working. So you will have your chance.
Does that resonate with folks? So HCA will report expenditures by HCP land APM category to future primary care advisory committees with the intent of developing a recommendation for a statewide target.
I so move.
And what's the year? Do we want to?
Shane, it looks like you have the second to the last line where it says primary care advisory committees. You might want to change.
Thank you.
Yeah.
Is the date on the reporting of the expenditures to the committee, or is the date on intent of, because 2025 would be like the next year. So I'm in terms of operationally being able to, you know, aspire. So like you're thinking incremental annual increases in 2025, like starting in 2025.
Oh, sorry, statewide target. That meant to be report. Do we need to specify to the committee? I guess what I'm getting at is it too presumptuous to say that the board would reinstitute the committee next year before it's done, even if we think it's going to happen?
I could go either way on it.
I mean, would the report actually be to the cost board because they are the parent committee for this work?
Yes, I think this committee will make recommendations for the cost board.
I'm gonna try and capture Cheryl's comment in chat.
Oh, thanks, Shane. I don't know if I don't feel like you have to. I just wanted everybody to know I didn't just make the number up.
Oh, fair. Yes. All right, let's read it once to make sure it still hangs together. I know this is an important one for a lot of people, but so the committee would endorse HCA efforts to track and set targets for primary care expenditures using the HCP land alternative payment model framework categories, with the goal of increasing the percent of primary care expenditures paid through population-based or shared financial risk-based payments. HCA will annually report expenditures by HCP land and APM category to future primary care advisory committee. I guess that would be plural, since it's future and there may be multiple, with the intent of developing recommendations for a statewide APM expenditure target aligned with the HCP land targets. Any additional revisions?
My only comment is I think we all know what the acronyms mean, but we didn't spell out any of the acronyms initially.
Bettina?
I guess I have a question on what if the the targets change for us, because we're saying that the HCP LAM targets, our targets align with theirs, and what if they are a moving target? So do we want to do this if they're aligning with them? Does that mean the same as them? And then we get back to what Cheryl had suggested with the 4B, because when you click on her link in the chat box, it says 25% by 2024, 30% by 2025, and 50% by 2030. I mean, do we just say that now before if the HCP LAN framework changes? Just a thought.
I have some insider information about that because the targets just changed after their initial setting a number of years ago. I think they are unlikely to change in the next 2 years for sure, because we just changed them. I think that is a good note to remember. So we'll have to sort of think about that next year when we talk about this.
Shane, the part that I pointed out where it says HCA will annually report expenditures. Yeah, there you go. Primary care advisory committees. I'm not sure if you meant for it to say primary care advisory committee meetings or if it's just primary care advisory committee.
Since it's annual, I was thinking that there's each year has its own committee and therefore it'd be plural, but I'm not at all up to it, so I could just remove it.
There you go.
Lon?
Yeah, I support this. And if we use the HCP LAN model, and using the top tier, right? So I think Cheryl, you were the one that says the goal should be population based or shared financial risk, which is 4B, like the top of the top. But I think every practice, it has a different baseline from an operation or capability standpoint. So I was wondering if there was a way to say like that is the ultimate goal, of course, but as they, we are holding their feet to the fire, it is to continuously move up, right, on this spectrum from category 1, fee for service, no link to quality and value, to eventually get to category 4. But I think as long as, depending on what their baseline is, some practices moving up to category 2 is an improvement.
That is definitely true. I think we should just leave this language as is and then talk about it next year, because we have 20 minutes left and a handful of votes to go. I would rather not have another meeting after this. In fact, we don't have time to have another meeting after this. So because we need to present this to the board in early July. So if that's okay, maybe I'll take chair privilege and see if there is a motion.
Motion to accept.
Any second?
Second.
Second.
All in favor of passing this recommendation, please raise your hand.
Shane, did you want to be on the last slide?
No, I want to be in this one.
Oh, okay.
It looks like there's 11 votes. So please lower your hand. And all opposed. Jonathan, your hand's still up. Perfect. All opposed, please raise your hand. Great, this recommendation passes. I certainly took a bunch of notes. I think as we get information, this will be a place we really want to dig into some more, and that'll be good. So recommendation 7.
Okay. Okay, so this is on the measurement strategy. Original language was the Healthcare Trust Cost and Transparency Board should evaluate the feasibility and appropriateness of using a primary care expenditure target based on aggregate per capita or per member per month expenditures instead of an aggregate expenditure ratio of 12%. If the board determines a PMPM or per capita target is feasible and desirable and targets are identified, the board should make recommendations to the legislature to replace the 12% primary care expenditure target with the revised PMPM or per capita target. So we go to our input. We received one input on from one person on this in terms of measuring using both strategies, but maintain the percent of total spend as primary. So then we had some recrafted language here using that endorses language. The committee endorses an effort by HCA to measure expenditures both on a PMPM or per capita basis and primary care expenditures as a percentage of total expenditures, and to make future recommendations to improve primary care expenditure tracking based on any findings. So essentially opening up, making the recommendation very much, let's explore this. Let's keep both calculations in the forefront, and then see what recommendations, once you have that lay of the data land, what recommendations make sense for future targets. So let's see, what questions or comments do folks have? I'm not seeing any hands right now. Should I kick it over to you, Judy?
Or do we have a motion?
Motion to approve.
Second.
Second. Perfect. All those in favor of adopting this motion, please raise your hand. It looks like we have 12. Yes. Please lower your hand, everyone. And all those opposed, please raise your hand. Great. This recommendation passes. You're on mute, Gretchen.
Thank you. Okay, so we are through all 7. That means we can move on to the overall recommendation package vote. If you want to highlight that last slide. Again, it's sort of this balance of very specific actions on the left-hand side for recommendations 1 and 2, and then sort of committee endorsements for the other 5, which all have some actors, sort of named in those recommendations. Do we have a discussion about this recommendation structure? Questions, alternatives? Okay, I'm going to kick it over to you, Judy, because I'm not seeing any hands.
Okay, excellent. Does someone have a motion to adopt this strategy of moving forward 2 policy recommendations and 5 committee endorsements? Is
Move to approve.
there any second? Any further discussion? Crystal?
Yeah, thank you. Just a point of clarification, as we regroup next year with a little bit more information on number 6, is it correct to say maybe potentially at that time it could move to more of a policy recommendation? This isn't our set strategy long term. Thank you.
Yeah. And we might change this all up next year, but we'll take a look at what progress has been made and whether we want to change anything. I think especially for 1 and 2, I think there are concrete recommendations for the legislature to consider, and that will potentially be a helpful step. Any other comments? Then those in favor of approving this, please raise your hand.
Looks like we have 11 hands raised, Judy.
Great. So lower your hands, everyone. And then all opposed, please raise your hand. Okay. This proposal is approved, and I will take it to the cost board, I think next week, the week after. It's pretty soon. I really like our rethinking of this, and I want to thank Shane and Gretchen. I think this is nicely packaged to have some endorsements to continue some of the work that's already going and recommend some concrete action steps. So hooray for us. And thanks for Gretchen and Shane for helping us walk through these pieces. So with this being our last meeting for 2024, I want to talk briefly about the next steps for our committee and when to anticipate us coming together again. So at the Healthcare Cost Transparency Board's Advisory Committee on Primary Care, our goal is to bring primary care recommendations to the cost to their legislative report. So since our task to the cost board this year has been fulfilled, we no longer have a need to meet for the rest of the year. I think we are interested in the data that's going to come in, and that data will mostly be available next year. And so we will have a pause and create a 2025 meeting schedule that will be emailed to you when it becomes available. I think we're actually working on some of the dates now, which seems amazing. And if you have any updates or changes to your contact information, please let us know. We'll make that one change that was talked about at the beginning of a new member being added to replace someone. If there's other changes, we'll do that. But then I anticipate we'll meet late next spring to look at the data on primary care spend and where we are, and see if we'll revise these recommendations. So are there any questions?
Yeah, hey Judy, will we just get an update on whether the cost board accepts our recommendations?
Oh yeah, that's a good question. I think we could send you all an email about that. Yes.
Thank you. And then I guess we just have to hold our breath and wait and see what happens with the legislative session, correct?
Yes.
Okay.
Yes. Well, after my thinking that we were not going to finish this meeting on time, we are at the end of today's meeting. And I want to thank the center staff again for all the help with today's discussion. I'd like to thank each of you for participating in today's meeting, as well as your hard work and dedication over our last meetings over the last year to work towards increasing primary care expenditures here in Washington. We do have a lot to do, so we'll be coming together again in 2025 to resume our work and hone or change any recommendations further that we made. But I think you should all feel really good. I feel like we made a lot of progress. We have a solid definition for primary care spend, and we have some recommendations for action to get us there. And I will bring those final recommendations to the cost board in July. And excellent work, everyone. The recording and summary of this meeting is going to be posted shortly on our website, and I look forward to seeing you all in 2025. The June 26th of 2024 meeting is now adjourned. Thank you, everyone.
Great, thanks everybody.
Thank
Have a good
you.
day.
Thank you.
Thank you.